Hello, everyone. Welcome to the PMP Pals Hope Zoom call. I've gone ahead and muted the lines as we all start to enter, and I click away here and letting people in. But as always, thanks so much for being here. We appreciate everyone. Excited to see everybody, and of course have Dr. Joel Baumgartner from UCSD with us today. Everybody's looking good today. Well, I think we can go ahead and get started. I anticipate I'll be clicking for quite some time to let people in, but let me just welcome everyone to the Hope Zoom call. Thanks again for being here, everybody, for the highlight of my week. And I know most of you here today, but I see some new faces. We'll go ahead and do introductions. And I'm Chris Pikarski. I'm the president of PMP Pals. I'm a 16-year survivor of PMP, and I'll start to go around with the leadership team as well. And Adele, would you like to introduce yourself today?
Sure. Hi, everybody. Adele. I'm the vice president of our board, and I'm a 9-year survivor.
Thanks, Adele. And I don't know, there's Charmaine coming in the waiting room right now. And so we'll jump to her in just a minute. But I'm going to introduce James. I see James Caldwell here. And James, I'll let you say hi. Give me a second here. I'll unmute you there. There you go.
Hi, everybody. James Caldwell here from Northern Ireland. I'm a 6-year survivor from a high-grade appendix cancer. I'm also one of the admins on the Facebook support group.
Thanks, James. Great to see you again. And Misty, I don't know if you can unmute. I'm going to ask you to unmute and say hello. There you are. And so Misty Price is in the leadership team of PMP Pals. I see she's unmuted herself now. And Misty runs the Get Well Cards program. Did you want to say hi real quick today, Misty?
Yes, I would like to say hi and welcome to everybody. And I would certainly love it if you would send me a request to send you a Get Well card. I think you would be very happy with all the response from all over the world that you would receive. So it doesn't matter where you are. We pay postage. So just let me know if you need a little cheer.
That's great. Thanks for being here, Misty. It's great to see you. Charmaine, I see you there. Would you like to say hello to everyone today?
Hi, everybody. Charmaine in Austin, Texas. I'm on the board, and I was diagnosed 23 years ago. Had my surgery 11 years ago. Doing great.
Nice to see you, Charmaine. And Adele, have I missed anyone to introduce? Is Michael here today?
I have not seen Michael yet, but maybe Connie?
Yes, Connie, one of our volunteers at large. Let me unmute you there.
Good morning. My name is Connie. My husband was diagnosed 5 years ago, doing well, and I'm in South Florida. Welcome.
That's great. Connie, we always appreciate you being here. I've had the pleasure of being at the conference with Connie, who's supported the organization, and gotten to know her and her husband. Her husband is Captain Chemo. If you haven't seen the pictures yet, you know, someone who makes the best of a bad situation and dresses up in all sorts of interesting costumes to keep the nurses at MedOnc entertained. So we appreciate you guys.
Thank you.
Yeah.
Welcome.
And so with that, I'm going to introduce Joel Baumgartner, but and say hello. Now, Joel, before you run your actually, you know what? Let me do one thing here. Let me get through the disclaimers, because it looks like the people entering has slowed down a little bit. So let me just set the rules of engagement for everyone real quick, so everyone knows how this works. And again, welcome everyone. This forum that we have, the weekly Hope Zoom call, is here to provide information and support for patients, but please understand we're not licensed physicians. We do have a medical physician today. We're grateful for Joel being here, but we're just providing some advice and information. We're not providing training or any medical information today. You need to have your own licensed physician team, and but we'll help you find them too. That's part of what we do. We have reviewed the presentation today. There is no scary data or graphic images. There is some anatomy presentations or images that you'll see there, but nothing that you're going to find too scary. Please do understand that while we try and keep your identity and health information anonymous. We can't guarantee that. You're welcome to keep your camera off, and you're welcome to change your name. However, it can be tricky sometimes, and so we can't guarantee that anonymity. And please do understand, we do record these videos and share them so that the larger public can benefit from them. So your images will be shared if you're sharing your screen. And so that's how the forum works. Some more rules of engagement. So we're finding that we're having lots and lots of attendees, especially with the physician calls like today. So we're very excited about that. And please understand, you are not obligated to talk. For the physician presentations, we do mute everyone so we can keep the background noise to a minimum. But you're welcome to send emails to zoom@pmppals.net. We are monitoring that right now throughout the meeting. And so you can send an email and we'll catch that. And we do encourage people to use the chat function. Share your contact information if you'd like to. But a big part of what we do is emotional support for one another. And I just can't tell you how excited I am, how much my heart is warmed to hear every week how people are checking in with one another. I hear phone calls and emails throughout the week, and that's part of what we do. So feel free to use the chat. Then, so we do keep these to time. We'll keep this to an hour and a half today, so we'll end promptly at 9:30 Pacific time. And then finally, please keep up with us throughout the week, because we are posting on Facebook at the PMP Pals Network and on Instagram at PMP_Pals. So you can find us there throughout the week. And obviously PMPPals.net is our website, and there's lots of information there too. And so with that, I will turn to Dr. Joel Baumgartner and say, thanks for being here again. We really appreciate you. And you're going to talk to us about CT scans today.
That's right. All right. Thank you, Chris. Let me share my screen. Okay. Well, good morning, everyone, and thanks for inviting me. This is really always an honor for me to speak to this group. I've done it a couple times in person. I think this is a great format. Probably like everyone else, I found Zoom can be very good for certain things. I think this is great because people are from all over the world, it sounds like. And I see some familiar names and faces in the audience, so nice to see you. And I'll just launch with this. So Chris asked me to talk a little bit about CT scans and PMP, but I thought I would broaden it a little bit and talk about radiology in general and PMP. And as he said, for those of you who I don't know, so I'm a surgical oncologist at UC San Diego, and I've been here for about 8.5 years now. And cytoreduction HIPEC is a major part of my practice. And I was fortunate to join a big group here, so we have a good group of colleagues that I get to work with, and it's really an honor to be here as well. So with that, I'll get started. The first thing is a disclosure slide here, and I just want to disclose that I'm obviously not a radiologist. In many ways, I'm like Homer Simpson here. I'm a simple surgeon, right? My radiology brain for sure is that size. My surgical brain is probably a little bigger, but that being said, I'm going to give you my perspective as a surgeon for PMP and how I kind of interpret images. Obviously, I'm reliant, as everyone else is, on radiologists, and I certainly don't intend to be a radiologist. I don't play one on TV. I'm just going to give my perspective, but I think it'll be helpful. I think I always find it helpful to go through scans with patients, and I think it really does tell 1,000 words when you can see a picture of what's going on. So I'm just going to I'll basically go through. So what we're going to do this morning is I'll do a little bit of anatomy review. I think that's a big part of reading CAT scans in particular, especially in the abdomen. And I'll focus mostly on CT scans, but I will talk a little bit about PET and MRI as well, the technology, but also I'll show images of all these techniques, including those with PMP, to kind of help show what we look at as clinicians whenever we do look at imaging. And then we'll compare and contrast the different techniques, and then obviously happy to answer questions at the end. So, as Chris said, I don't have any gory pictures. I don't have any surgical pictures at all in this talk. This is the only really anatomy slide that I have. But I think it's important. I mean, a lot of radiology is knowing anatomy, and maybe this will give many of you PTSD from your high school biology days. I'm not sure, but the reality is that anatomy is very important when we review CAT scans or any imaging for that matter. And so this is basically kind of the what we see as surgeons when we open someone up. And I think these structures. I just want to point out some of these structures because we'll be talking about them when we look at CAT scans. So the first thing we see in the abdomen is the omentum, and I always describe the omentum as kind of a fatty apron that we all have, whether we're thin or large. We all have one, and it basically just drapes over the intestine. Hopefully you can see my mouse here. And then as we lift up, the omentum, it's connected to the colon here, and then underneath the omentum is all these loops of small intestine. And that's basically kind of what we see when we first enter the abdomen. And then if you kind of look a little more carefully in the upper abdomen, I obviously cut off all of these labels because I don't think there's not going to be a quiz at the end, I promise. But you can see that, the stomach is obviously being lifted up here. So the stomach is in the upper abdomen. Obviously the liver is in the right upper quadrant. This little green thing coming off is down here. This is the gallbladder. The pancreas lives behind the stomach. The spleen is kind of on the left side of the abdomen, tucked underneath the rib cage. And then in the lower, this is a view of the pelvis. This would be a female patient, but you can see the bladder here. The bladder is kind of in the front, or we call that anterior. Behind the bladder in a female patient is the uterus with the fallopian tube and the ovaries. And then behind the uterus, there's the colon, and the colon here is transected. But this is kind of just a rough view of the pelvic anatomy. And I just think, I just wanted to start with this because I think, as we kind of start looking at scans, it's helpful to kind of keep this in mind. So now I think it's also important to talk about the peritoneum, because that's obviously what we're focused on today is peritoneal anatomy. And so, most of you, I'm sure maybe all of you have know what the peritoneum is. That's where appendix cancer metastasizes, and that's what we often do surgery for patients. But the peritoneum covers the abdominal wall. It also covers the intra-abdominal organs. So I think that that's where we talk about parietal peritoneum is the part that's on the abdominal wall and diaphragms, and then the visceral peritoneum is on the organs themselves. And I think it's important to remember that the peritoneal surface covers all of those structures. And so, it can make it quite challenging to image the peritoneum. And we'll talk about that a little bit later. And then this is kind of a side view of the peritoneal cavity. So the peritoneal cavity is all this stuff in dark purple. And I think the point is the peritoneal cavity is a very big space. And in fact, the peritoneal surface, the surface area is actually the same size as the skin surface area. So the peritoneal surface area inside your abdomen is actually quite large. And unfortunately, if you have cancer there, there's a lot of places for these tumors to grow and hide. And so so it makes it also challenging from an imaging standpoint is to image the peritoneal surfaces. It's very challenging in many ways, and we'll talk about that in the next few slides. So I'm first going to talk about CAT scan. So CT scan, we call it. Computed tomography is the fancy name. I'm not going to get into much physics, mostly because, like I said, I'm not a radiologist. I'm definitely not a physicist. But I think what I'll mention here is that a CT scan is basically a three-dimensional X-ray, and so X-ray works basically by just emitting X-rays through the body, and the X-rays are absorbed by different tissues at different rates. And the more dense the tissues are, the more they absorb the X-rays. The less dense they are, the more the X-rays tend to pass through. And so this is someone's ankle getting a plain X-ray, and you see this, classic bony, appearing X-ray image. And you see the bones very well because they absorb X-rays very well. And so they tend to be bright. So on CAT scan or X-ray, things that are bright are generally more dense. And so when you just do a plain X-ray, you see the bones very, very well. You also can see some soft tissues here, right? You see this black area outside of the leg, but then you see this kind of hazy, kind of gray area. That's the skin and muscle and soft tissue that absorbs, you know, some X-rays, but not as much as the bone does. Well, a CAT scan is basically just a three-dimensional X-ray. So, you know, the patient lays on the gurney here. The X-ray tube is here, similar to the X-ray tube for a plain film, and then it, you know, passes X-rays through the body, and this thing spins around while the patient is moved through this donut, and the detector's on the back side, and then basically it uses computer algorithm to basically reconstruct all these X-rays to create the images that we see. So it's basically like getting a whole bunch of X-rays, and then they're reconstructed by the computer to form the images that we look at. But the technology is the same as a CAT scan. So it's X-rays. So its density is what it measures. So the CAT scan is a measurement essentially of density in the abdomen. So there's kind of four primary density categories when we look at a CAT scan. You think there'd be more than this, but they're kind of can be lumped together into four. And I'm going to go from the least dense structures on a CAT scan to the most dense. So the least dense would be things like air. So obviously air has very little density. It's air, right? There's nothing in it. So the air on a CAT scan of the abdomen is often manifested in the lungs. So this is a CAT scan of the upper abdomen. And I'll show some orientation, a slide, I think the next slide, I'll show how these CAT scans are oriented. But this blue arrow is pointing to this really dark black area around the liver here. And this is actually a cut of the upper abdomen. And so it's getting some of the lungs. So the lungs are mostly air. I mean, there's obviously tissue in the lungs, but they're mostly filled with air. So they're not dense at all. So it almost is completely black because X-rays just pass right through that and it doesn't show up. So air is the least dense, the darkest on a CAT scan. The next least dense would be fat. And like I said, we all have fat. Fat is healthy and important for all of us. Some of us have more than others, but we all have fat in our abdomen, and you know, that's normal. And this is it's a little bit, you know, more dense than air, but not by a lot. And so the fat in this area shows up a little bit lighter shade than the jet black air. And it's hard to see on this picture, but if you blow it up, you can see the difference. Next dense would be fluid or soft tissue. And so this green arrow is pointing inside this structure here. This is actually the stomach, and there's fluid in this person's stomach, and it shows up as kind of a dark gray. Now, it's kind of confusing. Why does it say fluid and soft tissue? And that's because fluid and soft tissue actually have similar density on CAT scans. And we'll talk about that. But that can make it challenging to differentiate a solid tumor, perhaps, from mucin, right? That's a common problem we have with PMP is, you know, can we see actual solid tumors versus mucin? And actually, it's hard to tell the difference because they have very similar densities. And then the most dense structure on a CAT scan would be bone, right? So this is pointing to a rib here. This is the central thing here is the vertebral column. You can see more ribs over on the other side. But bone is very dense, so it absorbs a lot of X-rays, so it's very bright. Now, to confuse things even more, you can actually, and most of the time when we get CT scans, we give contrast. So we give IV or oral contrast. And this patient got IV contrast. So this round structure here is the aorta, actually. And the contrast is a bright material on CAT scans. So it's very dense material. So it shows up as very bright. And so we can highlight vessels. This person, you can also see there's some vessels within the liver here that have contrast within them. This is the spleen over here. And so organs that have a lot of blood flow can also be very bright, not because the organ itself is dense, but because it has a lot of vascular structures. And if we give IV contrast, it can make those structures show up. And then you can time the CAT scan based on when you give the IV contrast. So you can kind of preferentially highlight the arterial structures that go away from the heart or the venous structures that return the blood back to the heart. And when we want to image different organs, we preferentially use different phases of imaging. So CAT scans, like I said, are reconstructed into these slices. And the best analogy I can give is that it's like a loaf of bread, and your body is basically sliced up like a loaf of bread into a whole bunch of slices. And then those are the slices that we look at when we look at a CAT scan. And so the most common way to view a CAT scan is via the axial images. So those are in this plane here. So it's like you're cut basically like laying on the table, and the cut goes straight through your abdomen. It's a cross section. And so we're looking at this CAT scan kind of like the patient is laying on their back, and we're kind of zooming in and out through their abdomen. So that's called the axial plane. But the CAT scan can also reconstruct images in other planes as well. So the coronal images are ones that kind of go from they split the body from front to back. And so you're kind of looking at the patient from the front side looking towards their back. So it's a different view. You can see the vertebral column here. These are kidneys, liver, spleen. So it's kind of like straight through the abdomen looking from the front. And then you can also look from the side. So that's called the sagittal plane. That's almost as if you're cut kind of right down the middle of your body and you're looking at it from the side. And so we use all of these orientations when we review CAT scans, but mostly we're looking at axial images. And from here on out, I'm going to really mostly show the axial images because I think that's the most common way that they're viewed. But we definitely use all the different formats when we review CAT scans.
Now, Joel, can I ask a quick question? And you're probably going to answer this question right as I ask it. You're going to answer it. But as we look up at the axial image, are we looking from toes to feet? I'm sorry, toes to head, or are we looking down?
Yeah, great. That's a great question. It's a confusing thing. So let me show you best on this picture. So this is essentially a normal CAT scan that I'm going to show, and I'll just quick zoom through it here, and then I'll show everybody what we're looking at. So yeah, so this is a cross section of someone, and basically they're laying on their back, and we're looking from the side of the feet. So what's confusing about it is their feet would be out of the computer screen pointed towards us. The head is behind the computer screen. So what that means is this side on our left is actually the patient's right, because they're laying on their back, their feet are towards us, and as we're kind of scrolling through the slices in their abdomen, the patient's right side is actually on our left side of our screen. And then vice versa, the right side of our screen is actually the patient's left side. And that's what basically this is. So these are all slices through the abdomen as we kind of scroll through this. And let me just kind of show you a couple of representative cuts here. So this is a slice through the chest. And, a CAT scan of the abdomen and pelvis always includes a little bit of the chest. There's some overlap between the different, anatomic domains. And so the heart here is very bright because the patient got IV contrast. So this big bright round thing is the heart right in the middle of the chest. Outside of the heart, you see these very dark lung tissues, and those are dark because they're air, right? So they have a bunch of air in them. And then we'll scroll down a little bit more here into this cut. So this is a cut through the upper abdomen, and you can see this big kind of round thing here is the liver. Very big structure. So this is in the right upper abdomen, right? Remember, this is the right side, this is the left. So the right upper abdomen is where the liver sits. It's got some vessels within it. It's pretty homogeneous, though. It's pretty much the same density throughout its structure. So you can see it's actually really easy to see little tiny liver tumors if they were here, because we can actually differentiate them pretty well. This patient has none of those, but if they did, it would show up as a little round area. And then this little triangular thing is actually the spleen in the left upper quadrant. And it looks similar to the liver in terms of density, but it's just smaller. And then this kind of round, kind of irregular bordered structure here is actually the stomach. So this is the outside, this is the wall of the stomach, this kind of lighter gray color, and then inside the stomach is actually fluid. This is probably the breakfast the person had, is sitting in the stomach. And it's got this kind of rough surface because that's exactly what the inside of your stomach looks like. It's got these little folds that are normal. This round thing here is the aorta. And then, as I said before, there's some fat in the abdomen here, which is normal. But this is a cut through the upper abdomen. So, and then, I'll scroll a little bit further down here. This is kind of a cut through the mid-abdomen. These are kidneys. So the kidneys are in the back of the abdomen. They're actually outside of the peritoneal cavity. They're very bright because they take up the contrast that is given is excreted in the bladder and the urine. So they're very bright. And then these round things here is small intestine, probably. So these are little loops of small intestine. I'll go a little bit further here. This patient, so they're actually measuring something here. This is a radiologist that put this on the scan. I couldn't take it off. This is actually a big cyst this person has on the liver. Unrelated, it's benign, unrelated to any PMP issue. And we can talk about incidental findings perhaps later, but you know, we often see other things on CAT scans that we weren't intending to, and cysts of the kidney are very common. This is obviously, this is pretty big, but it's likely innocuous and harmless, and this person probably has had it their whole life. But the reality is, you know, the radiologist here is measuring it. So you can measure things. You get, there's little calipers you can put on here, and you can measure how big things are. This is, you know, 556 millimeters, so 5.6 centimeters. But let me scroll down a little bit down. Let me look right here. So this is a cut a little bit lower, and this structure going across here. So there's, you see these little dark circles. Those are actually air bubbles inside the colon. In fact, this is actually the colon here. The colon normally has air. There's bacteria in your colon that make air, that we pass gas, and that's what that air comes from. So you can see that air in the bowel. That's normal. Little gas bubbles inside the intestine. And then I'll scroll a little bit further down here. You can see this is more small intestine. It's round. It's got some fluid within it. And then you can, you know, and you can see not all these circles are the same size, because remember, the intestine is this whole matted nest of intestine. And sometimes when you do a slice, you're going to see an intestine that's kind of cut right down the middle, and you're going to see other times where it's kind of on the side. And so it's going to look a little different on how it's oriented. And then down in the pelvis, I'll kind of show this down here. This dark thing is the bladder. This is the rectum here. You see a couple little air bubbles in the rectum, and then this is actually the uterus, kind of in between the bladder and the rectum. You can kind of see, and there's these little punctate, really bright little dots here, almost like Christmas lights. Those are probably little calcifications in the pelvis that are pretty normal. You know, little pieces of calcium either in vessels, or sometimes the uterus itself can have them, and that can be a normal finding. So, and then these little bright things here are the hip bones, right? So you can see the ball and socket, right? We had talked. This is a really nice view of a orthopedic surgeon would like this, but you know, this is the hip joint as it goes right into the pelvis. It's like ball and socket kind of anatomy there. So yeah, so this is a normal CAT scan. So let me go now to some abnormal ones, and we can kind of talk about kind of what we see when we look and look for PMP findings. So the normal CAT scan is over here on the left, and then an abnormal one is here on the right. And so hepatic and splenic fluid. So, you know, ascites, right? Ascites is a common finding in patients with PMP. It could be just mucin, it could be serous ascites or watery fluid, but in any case, there's fluid there. And it's nice to have the side-by-side images, because you might not pick up on this, but if you look at the liver here, you see this kind of darker gray material right around the liver. You see it best right up in here on the top part of the liver. If you look over here, you don't see that. You see fat that goes right up to the liver, and then, you know, this is actually part of the chest wall. But there's this stuff in between the liver and the chest wall here, and that's ascites, that's fluid. So we call that perihepatic fluid. And the same thing applies over, this is a spleen. This is actually a pretty big spleen, but you can see there's a little faint rim of fluid that kind of goes all the way, not quite all the way around, but nearly around the spleen. Over here, you just see fat go right up to the spleen. It's dark and then a bright spleen, but here you see a little bit intermediate gray, and that's actually fluid that layers out right around the spleen. So, you know, when you lay on your back, if someone has fluid, it kind of layers in the back part of the abdomen, and that's what we see here. So that's actually, you know, that's actually the spleen. So, or fluid rather. So next, sometimes you hear the word scalloping. So we talk about that word, hepatic and splenic scalloping. Well, it just comes from a scallop, right? A scallop shell has these kind of ridges in it. And when we see fluid on the liver, but we see these indentations in the liver surface, that's what we mean when we say scalloping. And usually what that indicates is that material is kind of pushing into the liver. So this is probably not just fluid on the surface of the liver. It's probably mucinous disease. It's probably mucin that's forming cysts and then pushing against the liver surface, and it kind of indents the liver. And what that means, you know, from a surgeon standpoint is it means that, well, there's going to be some disease around the liver that we're going to have to peel off the liver because it's kind of pushing down into the liver surface. And the same thing can happen on the spleen. You can kind of see these little indentations on the spleen that normally shouldn't be there. And that's what we mean when you say scalloping. Sometimes you hear that word, but that's basically what that means. Next, we're kind of just working our way down the abdomen, and I'm showing some other abnormalities. So periportal disease, right? So what I mean when I say portal, that's the portal vein. So the portal vein is this structure here that drains blood from the small intestine and bowel and drains it into the liver. So when we eat, you know, we absorb everything we eat, hopefully, goes into our bloodstream, and that blood is first passed through the liver before it goes anywhere else in our body. And that gives the body a chance to kind of filter what we eat and get rid of any toxins and start to process the nutrients that we ingest. Well, that big vein that it goes to the liver in is the portal vein. So it's a big vein that goes to the liver. It's about the size of my thumb. It's a huge vein. You know, in this scan, you know, you see the portal vein going into the liver edges are against it. And then on this scan, you see all this kind of darker gray stuff right around the portal vein. And that's mucin or tumor. You know, that's the PMP basically right around the portal vein. I'll show this little cartoon here. This is a drawing of this structure, but the portal vein is this dark blue thing as it goes up into the liver. Obviously the gallbladder is nearby. There's a big artery over the top of the portal vein, you know, the bile duct. So we call this the porta hepatis or the portal triad sometimes because it has the portal vein and the hepatic artery and the bile duct. It's an important area, and you can't just cut across this because that keeps the liver alive. So unfortunately, let me go back here. There we go. This can be a real challenge, right? If we can't peel this material out of this region, you know, we have to be very careful not to tear the portal vein because it can bleed, and we can't just divide it because it's necessary to keep the liver alive. So this can be a problem area for us, you know, surgically. But it's an area that we always look at when we look at CAT scans. Is there periportal disease? Is there disease around the portal vein? Next is perigastric disease. And so this would be a tumor that's around the stomach, right? Gastric means stomach. So once again, normal scan over here, this is the stomach right here. So this structure right in the upper abdomen, it's got some gas in it. We always have gas in our stomach because we ingest air when we swallow. And so that gas shows up as a little dark circle or dark bubble in the stomach. But then the stomach also has some fluid in it. This is it's a cross-sectional view, but the stomach is kind of long. So you kind of see this long stomach here. In fact, some of this might be the duodenum itself, which is the first part of the small intestine, but we kind of see it all together here. And once again, fat comes right up to the edge of the stomach. The liver edge is right up against the stomach, just normal. Well, in this picture here, you see, once again, all this kind of dark gray stuff. And so you're probably learning to see already the dark gray material is the disease. That's the mucin. That's what we don't want to see. But we see it kind of basically completely surrounding the stomach here. You know, the liver is way out here. It's pushed away probably, and there's a bunch of you know, stuff in this space. And you can imagine, you know, this is what causes symptoms. The stomach gets smushed by the mucin, and you know, the patient may have trouble, you know, being able to eat a full meal or get full really quickly. And you can see how that might happen because the stomach has no room to expand. You know, the stomach is normally just an empty bag, but then when you eat, it fills up and gets very large, and it stores food until you digest it. So, but in this patient, they may not be able to do that. So obviously, this shows a bunch of disease around the stomach. Then we talk about the omentum, right? I showed that picture at the beginning of the omentum, that fatty apron. It lives on the top of the abdomen. So remember, this is the top of the abdomen here. And, you know, this person doesn't have a very thick one, but some people it's thicker than others. But this is normal. So this is, you know, intestines, colon is up here. This is that cyst I showed earlier that's not related to PMP. But, you know, there's this nice black kind of layer up here, that's the omentum. Well, in this patient, right where the omentum should be, you see these like round things here, and those are tumors. Those are little tumors in the omentum that they're little mucinous tumors in the omentum, and so we, omental nodules, we call that. And sometimes you've probably heard the word omental cake, and that just means that the whole omentum is basically replaced by these tumors, and it's like this big, thick cake-like structure. Cake is a terrible term for it. I don't know how it got that name, but that's what's used. But omental nodules or omental caking or omental infiltration, it's all the same thing. It's tumors in the omentum. So that's what that is. And then, as we get further down in the abdomen, you can see in the right lower quadrant of the abdomen, this is an appendix mass itself. So in this patient, this is actually the normal colon. It's got gas in it. There's kind of this dotted looking stuff. This is actually just normal stool in the colon. And then there's kind of these round, pretty homogeneous, meaning they're pretty, they don't have differences of density within them. They're probably mostly fluid filled, like cysts. And this is actually an appendix, mucinous tumor. The appendix normally is much smaller. So the appendix can be, if it's normal, can actually be hard to see on the CAT scan. So I don't have pictures of showing the normal appendix here, but I guess I could have. But this is an abnormal, this is actually a big mucinous appendix that's here. And then in this patient, it's actually over to the side. So this would be the cecum, the first part of the colon. And then this is a big mass here that basically has replaced the entire appendix. It's like this big fluid-filled thing. And, it's hard. I'm showing you one image, and obviously, in a real CAT scan, you can scroll up and down, so kind of get more of a three-dimensional view of this. But I only included the one video in this because it makes this slide presentation very large and makes it kind of freeze up all the time. So I only have the one video. But yeah, this is an appendix mass over here. And then the last couple of pictures here are of the pelvis. So this is in the lower abdomen. You see these big bony structures here. This is the big pelvic bones that you can feel in your lower abdomen. This is loops of intestine. It's very bright because in this patient, they got oral contrast. So this patient swallowed that wonderful contrast material that probably many of you have had. But that's what we see when we do contrast. It's in the intestine, and that's normal. But what's not normal is all this fluid around the intestine, and that's probably mucin or ascites of some sort. That's in the pelvis. This round black thing here is probably actually the rectum, as it's in the back of the pelvis here. But this is a bunch of fluid in the pelvis. And then over here you see this real round thing that's got this little lighter rim around its surface. This is actually a pelvic mass. It's probably a big pelvic cystic mass, and this is probably a big ovarian metastasis, right? So many patients with PMP can have disease in the ovary. And that's often what this will look like, is a big cyst within the ovary. And so it's walled off. So see how this basically is kind of surrounds and finds its way all around the intestine. This one kind of is pushing everything out to the side, and it's got this big structure. So if we go in, we see this big round cystic mass. I mean, this thing is huge. It's probably the size of a basketball, I would guess. But it's obvious, it's quite profound on the CAT scan, and it kind of pushes everything out of the way. And so that's a big pelvic mass. And I think in this patient, if I recall, I think it's a big ovarian mass. All right, so I'm going to jump ship here to talk about a couple other types of imaging that you might have received yourself or heard about, and then I'll kind of compare and contrast, and then we can answer some questions at the end. So PET scan. So PET scan, positron emission tomography is the fancy name, but PET works great. PET's much easier to say. We like PETs. So PET is basically it's a dye-based type of imaging. So the dye is this fludeoxyglucose, or FDG, we call it FDG. So it's a radioactive glucose, basically. So this is a glucose molecule, and it's got a radioactive label put onto it, a fluorine that's radioactive. And so it glows, right? So it uses a special imaging technique that actually can pick up these glowing structures. And any tissue that takes up glucose will show up and glow on these scans. And so, that can include normal things like the heart or the brain, because they are very active and they're always using up energy. And so they always show up very bright. And then the dye is also excreted in the urinary system. So the bladder and the ureters and the kidneys are also very bright. Now, the problem is that the images you get from just the PET scan alone are very fuzzy. So that's actually this picture in the middle here. So this is what just a PET scan alone looks like. It's very fuzzy. Yeah, you can kind of see some structures. You know, there's like probably liver here. Not sure what this thing is. This is probably a kidney. I don't know. There's something very bright in the chest here. I'm not sure what that is. But a PET scan is generally done with a CAT scan. So that's why usually you get a PET CT scan, not just a PET scan alone. So you also get this CAT scan over here on the left. And then what happens is then the technology then fuses these two images. So it layers the PET scan on top of the CAT scan. So that way you can see some anatomic structures. And so then you can see, oh, okay, so this is actually the liver for sure. This is probably a big spleen. This is definitely a kidney. This patient probably has something in their chest that's bright that probably shouldn't be there. These are lungs, you know, and then you can scroll, just like you can scroll on a CAT scan, you can scroll up and down or left or right or top to bottom. And, you know, you can view it as a fused image, we call it. So that's a PET CT scan. There are places that do PET MRI scans as well, but I think most institutions, you know, use PET CT primarily. So what does it look like and what do we find? You know, PET CT scans, I'm personally not a huge fan of them for PMP myself. We can talk about that at the end if we have time. But in general, it's because it's hard to see. PMP is really, and mucin in particular, it doesn't show up very well in the PET scan. But in this patient, you kind of have to squint a little bit. So, you know, so basically this is a fused image. The kidneys are back here. They're normally fairly bright. So anything that's yellow or pink is taking up this radioactive glucose. So it's kind of glowing, if you will. So the kidneys are very bright. There's these big round, very bright things. That's actually normal. That's actually the ureter as it's leaving the kidney. We're seeing it in cross section, but it shows up as a very bright round ureter, and that's normal. That's just normally what happens. So that's not a problem. What is potentially abnormal in this is that you see there's kind of this layer almost like all the way around the abdomen. This is probably a little bit of the liver edge here, but starting here and kind of coming across the abdomen and down to the patient's left side is this kind of pink, you know, layer. And that's probably an omental cake or omental infiltration that shows up as very bright on the PET scan. And once again, you know, PET scans generally, the more active the tissue is, the more bright it is. So the problem is slow growing tumors like many PMP tumors, you know, many appendix cancers are actually, you know, they're not active enough to take up this radioactive glucose. So they're often not very bright on the scan. So that's why, you know, I'm, you know, certainly with low grade tumors, I'm not as big a fan of PET scans. With higher grade, more aggressive, you know, appendix cancers, signet ring cell varieties and other types, PET scan's probably better because it takes up that dye a little bit better. This is another image of a pelvic view of another patient. There's a very bright thing here on the side of the pelvis. This is actually the colon, and they probably have a tumor right on the colon itself that's very bright. So, you know, we'll talk about pros and cons of some of these scans in a little bit, but this is what some PET scan images look like. And then moving to MRI. So MRI is, you know, uses a magnet. So it's a totally different technology than X-ray. So there's no radiation with MRI. It uses a very strong magnet. And you lay in that little tube. If any of you have had MRIs, you know what I'm talking about. It can definitely induce claustrophobia because you're in this little narrow tube for a long time usually. And it's a very powerful magnet that basically aligns kind of the molecules in your body, mostly hydrogen. So really it's mostly water-based. But it aligns these molecules, and then the magnet is turned on and off. And as it's turned off, those molecules then relax back to their normal orientation, and they emit a little energy signal, a little, you know, a wave of energy that can be detected. And so as those molecules differentially return to their normal state, they emit different amounts of energy, and then that can be detected and then processed into an image. There's a lot of hand waving, I realize. There's a lot of physics involved that I definitely don't understand. In fact, most most large institutions actually have physicists that work on the MRI machines because they're complicated. You can also give various contrast agents. There's very many different kinds of sequences when you get an MRI. You might see 30 different, different slices because they're timed differently and they use different techniques. You can see the difference here. This is an X-ray of someone's hand, similar to the other X-ray I showed. The bone is very dense and very bright. This is what an MRI of someone's hand might look like. So it's not showing density. It's showing the different enhancement of different tissues. And what we're seeing, this bright area here, it is bone, but it's not actually the bone, the firm part of the bone. It's actually showing the bone marrow inside the bone is very bright. So it's a little confusing. So bright things on an MRI are not necessarily more dense. They're enhancing, they're releasing this energy from the alignment of the magnet in different ways. And that is kind of exploited to get an image. So it's a little bit harder to interpret. But I'll kind of show a couple pictures here. So this is a pelvic mass. This is an axial image. You can orient the MRI just like you orient a CAT scan, axial, coronal, sagittal. But this is an axial scan of the pelvis, and there's this big kind of round thing in the pelvis that's probably a big ovarian mass as well. This thing up here is probably the bladder. It looks a little bit like a CAT scan, but remember the tissue, the different colors in the tissue here are not density. It's a different energy emission, and that is exploited to get the image here. So, but you kind of see this big round thing here. This is a big tumor in the pelvis, and then this is a little more subtle. This is on the upper abdomen. So this looks like the liver. You've seen enough pictures now in the last few minutes where you probably recognize this. This is the liver. It looks normal. This is the stomach actually, and then this is the spleen. And the spleen should have a nice, crisp border, but as you get out here, it kind of has this rounded kind of nodules on its tip here, and that's actually little mucinous tumors that live on the tip of the spleen, and you can see that very well on the MRI here. And there's maybe even a little bit back here. If you squint, you can see a little bit darker area along the edge of the spleen. So once again, this patient had probably multiple sequences, and this was only really seen on the one sequence, but that's kind of what we're looking at when we look at MRIs. So just a couple minutes left. I'm going to just kind of talk a little bit about pros and cons of each type of scan, and then talk about some limitations and maybe future directions, and then I'd be happy to answer some questions. So CAT scans, I think the advantage of CAT scans, and the main reason why we use CAT scans a lot for patients with appendix cancer, is they're very quick to perform. Probably all of you have had CAT scans. It's about 30 seconds basically to go through the big donut. It's pretty quick. I think most surgeons are certainly more familiar with them, certainly medical oncologists as well. I look at CAT scans virtually really every day. So we get very comfortable reading them. There's very good anatomic resolution. It's actually pretty good to differentiate, vascular structures, and we can kind of tease out anatomy pretty well. And the cuts, I didn't mention this, I think it was in my slide, but the slices are actually pretty narrow. They're only a few millimeters in thickness. So you can actually get pretty good resolution. So that's how thick the slices of bread are as we look through, right? So if the thicker the slice, the more likely you are to miss things in between the slices. But on a CAT scan, if it's thin sliced, you can actually see pretty well. The downside of CAT scans, the big one is it's radiation, right? So you do get radiation when you get a CAT scan. You're getting X-rays. So how much radiation? I'm not going to go into all the physics of the doses and everything. Over time, it's gone down. Physicists have been able to kind of tweak CAT scanners so you actually get a lot less radiation from them than you used to. But I think the point is, for a normal CAT scan of the abdomen and pelvis, one CAT scan, it gives you actually about 3 times the normal radioactive radiation dose you would get as a human living on Earth, basically. So, most of us get there's natural radiation that comes from outer space. There's radon that lives, in the ground and comes up through the ground. So we're all exposed to some radiation. But a CAT scan gives you actually about 3 times the normal amount you would get in a year. However, it's still a pretty small amount. And in fact, it's about 1/5 the maximum annual dose of like a radiation worker. So there's federal regulations, like people that work in a nuclear power plant or around radiation, they're obviously very regulated in terms of how much radiation they get. And so one CAT scan gives you about 1/5 of the annual dose that a radiation worker is allowed to get. So, you know, it's definitely some radiation. It's not, you know, it's not a huge amount, but it can be cumulative and it can add up. The other downside of CAT scan, and this is true of all imaging, is it can miss things, right? And so we haven't talked much about that, and I'm sure there'll be questions about this, but, you know, the sensitivity, meaning what is, you know, how accurate is the scan is a way we measure sensitivity. It's about 85%. What that means is, in general, CAT scans can miss about 15% of lesions, depending on their size and location. So you can still miss a lot of disease on a CAT scan. About 50% of intestine or mesentery lesions can be missed on a CAT scan. So the mesentery and the small intestine is notoriously very difficult to image, certainly by CAT scan. And so that's a limiting factor. That's why it's hard to see how much disease is on the small bowel. And then lesions that are very small have very, you know, the sensitivity is very low. You may miss 75% of lesions that are less than a centimeter in size. So that's the big downside of CAT scans. MRI, well, the advantage is there's no radiation, right? So there's no radiation exposure, period. It's a magnet, so certainly no risk from there. It may be better to image certain parts of the abdomen with MRI. So there's definitely advocates that like it for intestine or mesenteric imaging. Or even the peritoneum in general. It might be slightly better than CT, depending on the sequence that's used. The downside is it's a much more complicated procedure. You have to lay still in that little tube for at least 30 minutes, really, for an abdomen pelvis, sometimes even longer. So it's not, you know, it's a little bit, you know, can cause claustrophobia. It's a little bit harder to interpret. I think most surgeons, certainly this surgeon, myself, you know, I'm way more comfortable reading a CAT scan than an MRI. So I'm much more reliant on the radiologist for the MRI, which is fine. They're great at what they do, but it does make it a little bit more institution specific, right? So if your institution is not familiar with, you know, peritoneal surface malignancies, it's going to be harder for those radiologists to read those MRIs. Just like anything else, you know, a lot of radiology is pattern recognition. It's just seeing a lot of images over and over and over, and you get comfortable with it. And, you know, centers that do a lot of MRI for PMP or other, you know, peritoneal surface malignancies get really good at picking out, you know, small lesions. The problem is if it's an institution that doesn't see a lot, it's not so good. And, you know, so it's probably interpreter specific, more so than CAT scans. You know, it's a lot more reliant on the read of the radiologist. There's also probably a little bit less anatomic resolution on the MRI than there is on a CT scan. So that's one issue. And then PET scans, well, the advantage of PET is it's your whole body. It's a functional scan, so it can tell you how active these tumors are. The problem is, though, is it gives you more radiation than a CAT scan because you're not only getting the X-rays from the CAT scan, but you're also getting the dye, which has some radiation in it. And you also, it's a total body scan usually. Usually it includes head, you know, chest, abdomen, pelvis. So it includes a lot of X-rays. And the quality of the CAT scan portion of a CT on a PET is not as good as a regular diagnostic CT in most institutions. So the CT is not usually as good as if you just ordered the CT scan. And then, you know, low-grade tumors and mucin in particular doesn't really show up very well on PET. So it's not to say it's not used, but, you know, that's one big limitation of it. And the lower limit of detection is definitely about 1 centimeter for PET. So, you know, small little lesions, and many times PMP is tiny little nodules that may not show up on PET. So that's kind of the pros and cons of different imaging. You know, there's obviously other ways that we survey patients, you know, after surgery. Now, obviously, you know, many people get imaging at their initial diagnosis, but, you know, if we're able to do cytoreduction HIPEC, you know, we like to follow patients, and, you know, the imaging is certainly limited for that because it can miss small little lesions, which is exactly what we're looking for. So, you know, as many of you know, we also follow tumor markers, you know, CEA, CA19-9, CA125. They're not always elevated in PMP, you know, so it can be a challenge. Laparoscopy, we certainly use a lot of laparoscopy at UCSD. The problem is if you've had a big surgery, laparoscopy gets really difficult to do because of scar tissue. and it's also invasive. It's a surgery, right? So it has risks. And so, you know, we're certainly looking at other technologies. You know, I've talked about this, I think, with the group before, but circulating tumor DNA is certainly one direction that we're going. You know, there's other blood-based tests that are being developed to look for different cancers and recurrence of cancer in the bloodstream, and pretty exciting. We're not quite there yet, I don't think, but hopefully in the future we'll have other things to do besides just imaging. So I've been talking for a very long time, but with that, I'll stop and happy to answer any questions.
Well, first, Joel, thank you. I'm Dr. Baumgartner. Very terrific presentation. I've learned a lot. I'm going to give everyone a chance to use their reaction button on the bottom and do a little applause to thank for the presentation. Really, really educational. I learned a lot today. So thank you for doing that. I have aggregated some questions through the chat there, Adele, but I don't know if you want to ask some of the other questions first, or however you want to do
sure.
this.
Why don't we tackle the questions we received in advance? So, okay. And some of this I think you did address during your presentation, but you know, we'll just go. So if a CT scan shows scattered acellular mucin, but the biopsy samples did not show any cancer cells, what usually happens to the mucin? Can the mucin remain dormant, or does it usually spread or reproduce?
Yeah, that's a common scenario, unfortunately, right? So a CAT scan doesn't know the difference between a deposit of mucin that literally is only mucin versus one that has, you know, cells that are within it, right? And even on a biopsy, you know, that can be challenging because there's sampling error issues, right? You have a big deposit of mucin, you stick a needle into it, send it to the lab, we might just see mucin in that sample, but does that really tell us that there's no cells within there, you know, in that collection making mucin? But in general, if there, you know, if we're confident that there's a collection of fluid and it's literally just mucin without any cells, the body eventually absorbs that. It takes a very long time. In my experience, you know, it can take weeks, months, sometimes even years for that to dissolve, but it goes away and it's harmless. But, you know, the problem is usually where we see mucin, there's unfortunately usually cells there that as well, the tumor cells that make the mucin. And so if there's tumor there, cells there, then it's not going to go away. It's going to continue to grow. So that's why we get serial scans many times. But yeah, the CAT scan, unfortunately, can't really tell the difference.
Now, Adele, I have a quick question in regard to the mucin. So, and Joel, you may not have any opinion on this because this is new, but there's a lot of discussion in the community about Bromac and what Professor Morris is doing in Australia. One thing I'm wondering about that is if we start to use that technique with the mucin and dissolve it, is there potential for spreading potentially some of those cells as well around the abdominal cavity with that technique?
Yeah, I think that's always been a concern with that technique is that, you know, and they looked at this, I know, and I've seen some of his presentations and some of the animal models that they looked at before they started doing it in humans. And that was a concern, right? That maybe you're like softening up this mucin and it's allowing these cells to actually scatter a little bit more, right? Maybe the mucin is keeping them trapped in one place. I don't think they've seen that as I mean, I obviously don't have a lot of, you know, we don't use that technique here. And, you know, I certainly haven't done any studies on this. So, you know, but that'll be my disclaimer. But as I recall, I don't think that that was a big concern, at least in the animal studies they did, you know, and then in the human trials, I haven't been aware that that's happened. So yeah, so I don't think that that's been a reality. I mean, I think that the challenge is, you know, many times there's so many different pockets of mucin that, you know, it's not just one big thing that you can dissolve all the mucin, aspirate it out, and we're good. There's often multiple little cysts, and you have to kind of inject each one of those or give the digestive enzyme to each one of those, and it can be a challenge. But they're working at it, and I think it's great. So
terrific, thank you. That's great.
Okay, another question that came in: is it possible to have a blockage of the portal vein?
It is. In fact, that's what happens. It depends how fast it happens, right? So that's actually what happens with liver disease. So when someone has cirrhosis of their liver, it's not so much the portal vein itself, but the liver is just so dense and scarred in that the portal vein can't push blood through that. And so when the portal vein gets blocked, what happens is you build other collateral vessels outside of the portal vein, and we call those varices. And so that's why patients who have like liver disease can have bleeding in their abdomen or in their esophagus, because they've built all these bypass collateral vessels around the liver. You know, if the portal vein is just acutely clamped, like let's say we're in surgery and, you know, we just clamp off the portal vein and leave it that way, that's, you know, the liver will die actually if it's done all of a sudden like that. So it actually, the portal vein supplies about 75% of the blood to the liver. So the blood is filtered through the liver, but it also provides, you know, nutrients and oxygen to the liver. And if you completely clamp it off acutely, then the liver actually generally won't survive. So if you get a big clot in the portal vein, that's another way it can be clogged. We like to give blood thinners and ways to open that up because that can cause problems.
Great questions.
Okay. Thank you. When there's something questionable seen on a CT scan, and I think you mentioned this during your presentation, that has nothing to do with PMP, what is the process for communicating these other things to the patient?
Yeah, that's a great question. And you know, our scans now are such good resolution. We find all kinds of things, right? I mean, we've diagnosed other cancers, you know, unfortunately, but many times it's you don't know what to do with it, right? And so, you know, what I tend to do, and I think we all do it probably similarly, but we you know, everyone that orders scans on patients has a slightly different approach. At UCSD, actually, the CT report is automatically given to all the patients. So every patient, and I think that's kind of happening more and more at institutions. You guys are all from different places, but most patients, and you can certainly request it, right? You can always request a copy of your report. And the radiologist, and just, you know, you go right to the conclusion or impression, and they'll itemize every finding that they have. And many times there's more non-cancer findings than there are actually cancer findings. And yeah, I mean, some of those things, you know, some of them need to be worked up. Some of them don't need to be worked up. It really just depends what you see. But yeah, you can't just ignore them, obviously, because we find things, you know, and, you know, there's cysts are common. So I showed that kidney cyst on the very early part of the presentation, super, super common, and almost always nothing needs to be done. And especially if it's a patient that's going to be getting multiple scans, we can always follow those areas and see how it changes. And the same is true for liver cysts. You know, liver cysts are often benign and they can be followed. But, you know, there's a lot of findings that we uncover by just doing a lot of scans. And yeah, we have to deal with them sometimes, have to figure out what to do. I don't think we can just ignore it, right? I mean, it's there, so we have to work it up.
So Adele, I want to pause and give a little advice at this point, right? So as we at PMP Pals teach patients how to advocate for themselves and how to be educated about their own disease, we encourage patients to ask for those reports. Joel, Dr. Baumgartner is correct. A lot of institutions are giving those to patients as a matter of course these days, but there's still a lot of us that have to request those reports. And we encourage you to read those reports. If you have questions, we'll show you Arthur Redding's email in a little bit. You can email askarthur@pmppals.net. And while he doesn't give medical advice, Arthur Reddig is a retired pediatric surgeon and can help answer some of your questions about the medical terminology you might see there. But we encourage people to get copies of those reports and read through them. So we encourage that. But there's also a bit of a warning that we give too, because, you know, the radiologists necessarily, and I'm sure Dr. Baumgartner will affirm this, but they're going to note everything that they see as unusual, including, you know, other tumors that might be found during the CT procedure, but they're going to list everything that they see as unusual. And sometimes that's just more than what's really going on or what needs to be addressed. And so while we educate ourselves, just be aware that there might be more things in there, and you should ask your physician about this. Say, hey, the radiologist noted this, or the radiologist noted that. But you can trust your physician when they say, yes, this is what that means, but you don't have to worry about it. You can take comfort in that answer from the physicians for sure. So I guess I'm saying, get your reports, read them. You might find some funny things in there, but if the surgical oncologist says, don't worry about it, you don't have to worry about it. That's the overall advice I would give.
Yeah, that's great advice. I agree.
Okay, and another question that came in. What might be some ways to treat adenocarcinoma that is poorly differentiated, that presents in the mesentery and the portal hepatic areas of the bowel?
Yeah, so yeah, I mean, that's obviously, focusing on treatment, not just diagnosing them. Yeah, that's a whole nother discussion, but yeah, that's a challenge, right? I mean, that's what we struggle with as clinicians who treat, patients with this disease. And higher grade tumors are always more challenging, specifically those that are around structures that we can't remove, right? And so, that's always the thing that we hope not to see when we, open someone up and look inside, is disease around the small intestine or mesentery or portal vein. So yeah, most of the time, if it's not removable, we're looking at, systemic therapies, whether it's chemotherapy or maybe some other form of targeted therapy. But usually it's some form of systemic therapy that we're looking at. Yeah, and those areas can be hard to image too, especially the small intestine, as I said. So, if you get started on chemotherapy, sometimes it's hard to even follow and see if it's actually working because you can't even see it on imaging, right? So we rely on tumor markers and other things sometimes to tell us if this chemo is working or not.
And maybe similarly with disease on the small bowel that doesn't even appear on the CT, how do you manage and monitor that?
Yeah, that's a tricky one. And, that's where maybe MRI can be helpful. So sometimes if we have a patient that we're suspicious they have small bowel disease and the CAT scan doesn't really tell us, that may be a situation where we personally will go to an MRI. There are institutions that just do MRI for everybody instead of CAT scans. And actually, even within our institution, I think if you pulled all the surgeons, the 4 of us that do HIPEC, I think we all are slightly different. So, there's a lot of variability, but I think that's a good use for MRI. It's not perfect. You still may miss, small bowel disease. And that's why, sometimes, if there's an option to do a laparoscopy and we're really suspicious, that's where we may do a laparoscopy, is just take a look inside. It's amazing that we have this amazing technology with, so fancy technology and computer algorithms, but still just looking at the intestine with the human eye tells us way more than any of the scans does. But the problem is we have to be able to get in to do that, and that's not always possible. So
another question, this is a very specific question, and it relates to the use of Avastin after CRS HIPEC. And so in this situation, there's signet cell undifferentiated, previous chemo and Avastin prior to surgery, and then 2 rounds after surgery. After the surgery, there's a CC score of 0. All pathologies came back negative. And so a decision is, one recommendation is to have Avastin and another is to not. And just wondered if you had any additional thoughts.
Yeah, I mean, it's something where the specific details of a particular case matter. In broad strokes, so it's hard to say exactly in one particular scenario, but I would say in general, we tend, especially if it's a higher grade appendix cancer, at our institution, our medical oncologists use Avastin quite a bit. So I think most of the times we favor it. Avastin definitely impairs wound healing and recovery. And so sometimes, we have to hold it for a while before surgery, and we don't like to resume it, within probably a couple months or so right after surgery. But eventually in our institution, we use it quite a bit. The data, there's, various data, and but there's not a lot, like most of there's not a lot of studies in appendix cancer specifically. So, most of the data comes from colon cancer. But in general, we do like to use it, at least at our institution. But, there's downsides, and, depending on other risk factors and other things, it might influence one way or the other. Yeah.
Okay. And I think the last question, I think maybe for your list, Chris, is how long does it take for low-grade PMP to grow?
Yeah, that's a good question. And I wish I had a simple answer. That's what we struggle with, you know, and, you know, I've certainly had patients in whom it's come back, you know, we start to see recurrence within a year after surgery, and it's all low grade, right? Low grade disease comes back, you know, within a year afterwards. And then certainly I've had other patients where it's 10 years or more before we start to see recurrence, even those that we get CAT scans regularly, or imaging. So that's why we do serial imaging, you know, because it's hard to predict. And, you know, I mean, I think, you know, patients that have like a high PCI score, right? So lots of a large burden of disease in the abdomen, that even if we can remove all of it, that's certainly a higher risk patient than someone who at the beginning only had very small spots of disease. The risk of recurrence is usually higher and shorter interval in the large volume patient. But it's variable. And, you know, that's one of the things that, you know, even low grade, you know, PMP or low grade mucinous appendix cancer, there's still a lot of variability I think we don't fully understand. And I certainly have seen a wide range of times of recurrence, but in general, it's usually on the order of years. I mean, usually it's a few years before we start to see any recurrence, if we see it at all.
Maybe Joel, talk a bit about too, right, after recurrence happens, right, what are the strategies today? I think, and I bring this topic up because I think in the past there may have been more of a strategy of go back in with HIPEC aggressively, but I think there's a bit more balance today, and watch and wait becomes more and more of a consideration.
Yeah, absolutely, especially in those patients where there was a long interval, right? I mean, if it comes back within a year, we're probably not super excited to go right back to surgery at that time, but maybe that may be a time where we may consider some chemotherapy or something, or, you know, but you know, if patient has had several years from their surgery and then we start to see a small area of recurrence, especially if it's in a location where it's not going to threaten any organ function for a long time, even if it grows, and if it's not causing much symptoms, yeah, I think most of us, if it's low grade, tend to favor just watching it very closely. Oh, you're like, okay, we see it, it's back, but you know, it may be many months, maybe even years before it grows enough to the point where we have to intervene. And you know, as we always say, you know, we don't like to operate just to make the CAT scan look better, right? Like, we can do lots of things to make the CAT scan look better, but we care about the patient, right? I mean, who cares what your CAT scan looks like? If you feel well and it's slow growing and it's not threatening any function, you know, we can kick the can and let's wait. You know, no one's excited about doing the surgery, especially a second time. So let's just wait it out and see how it goes. And, you know, many times we will have to do something eventually, but you know, who knows when that is going to be.
I love this form so much. I will always remember that we don't just do the surgery to make the CT scan look better. I love that. I've never heard that actually. But so let me do some translation for patients in that too, because as we've done these Hope Zoom calls, I mean, we've done 30 consecutive weeks now, and we intentionally, we do a physician call, and then we do 3 support calls where we're just checking in with one another, asking our questions. This is, and we've learned intentionally that that's necessary, because the emotional battle is, we used to say, equal to the physical battle. And we know how invasive HIPEC is, but I'm actually getting to the point where I'm like, it's actually, the emotional battle is harder than the physical battle, as hard as that might be to believe. So my encouragement to patients though is, while it's terrifying to think we have this disease inside of us, you know, I think that we're starting to think of it more of a chronic disease. And, you know, if we are asymptomatic and, you know, it's not causing problems, the best thing to do might be watch and wait. I know we've got watch and wait patients on the phone today, on the call today. So I think that can be emotionally distressful, but it may be the best strategy to take. So again, right, we encourage get multiple opinions. We can get you in contact with the specialist, and you can find out what's the right thing for you to do. Ultimately, that's the decision. But yeah, I think it's hard. We deal with this fear, but sometimes watch and wait might just be the best thing to do. And Adele, I don't know if you want to add any color to that as I prepare to go to a quick break and talk about our support programs and then ask the final questions. But anything you want to add to that too would be appreciated.
You know, just to pile on, the emotional resiliency of all of this is so important, as we all know and learn each week. And so, you know, that's why we do what we do. So we're here to support each other. But you know, it's something that stays with you.
For sure. And emotional resiliency does not mean that we have to tamp it down and bottle it inside. That means that when we do come on next week, we're going to talk about how we're feeling, right? Because I think the proper processing of those emotions is part of having our physical health too, because I think the balance between the emotional and the physical, if we just tamp down the emotions, it manifests physically. So maybe we'll see lots of new faces next week. But I do want you to know, and as I start to show,
well, I'll just give everybody, for people that are regularly on the call, just an update on Gary. Gary did have his surgery during the past week. You know, he texted, said it went well, and he's hoping to be on the call next week.
That's great. That's great. Thank you for sharing that, Adele. It's good to have the updates. Well, throughout the week and after the presentation today, you can stay in touch with PALS, and we have lots of ways to support you. You can always send an email to zoom@pmppals.net if you have trouble registering or you have questions. We've got questions that we've received today through that email. Feel free to send them throughout the week and we'll make sure to get them. We still have the Bare Bottom Bear support program. I have my Bare Bottom Bear right next to me right now. He's a little gift that we send for when you go for HIPEC, and he'll go through the some of the challenges that we go through in the hospital. So side by side with you. You can always send an email to info@pmppals.net throughout the week, and we'll answer your questions or connect you with people, with physicians, whatever you'd like. If you have questions about medical terminology, Ask Arthur is a PMP patient and retired surgeon, so he can help with those questions. Our most popular program is the Get Well Cards program. Please send an email to getwellcards@pmppals.net. Misty Price is on the call today. She administers that program and she loves making sure you get cards. Now is the time for us to support ourselves and to take advantage of these programs. We encourage you to do that. Send an email. We want to support you, and the people that get to support you, it does them great. It gives them a chance to give back too. They want to do that. So we'd encourage you to do that. Finally, as if you're new on your journey, send an email to starter kits. We've got great stuff in there, like hand sanitizer. We've got some notebooks so you can take notes, information on PMP, and some other things that are going to be helpful throughout the journey. Finally, we'll remind you that we are a fully donations run organization. You can go to pmppals.net to make a donation through PayPal, or you can sign up PMP Pals as the organization you support through smile.amazon.com, and we'll get 0.5% of all your purchases. And it's a little bit of money, but over time, it all adds up. And
also, Chris, thanks to everybody that participated in our Giving Tuesday campaign. So our sincere thanks.
Absolutely. Thank you so much for that reminder, Adele. I appreciate that. Yes, there was a lot of work in the background to make sure we were getting the word out, and you responded, and we're so grateful for that. That's going to help us continue these programs to support patients and caregivers. And so throughout the week, we hope to see you at pmppals.net, our website. And then the Facebook page is PMP Pals Network. And then Instagram has inspiring messages and photographs throughout the week. You'll find that at PMP_Pals. And so with that, I'm going to ask just a couple more questions that I saw in the chat and ask those of Dr. Baumgartner. So Jill says, do we alternate between different types of scans for accuracy sometimes? Is that sometimes a method that you'll use, Dr. Baumgartner, to see disease?
Yeah, so exactly. So, I mean, it's a little bit of an apples and oranges thing, right? So if you've always gotten CAT scans and then we suddenly switch to MRI, we may see some differences, and that may just be a function of the different scan technique. But yeah, in general, sometimes it's worth getting a different type of scan, or a PET scan. Maybe like someone's tumor marker is rising, but the CT or the MRI don't really show very much, but we're really suspicious that there's something going on. That may be when we get a PET scan or something. So yeah, we definitely can switch modalities.
Good. Okay. So Here's a question from Melinda about different physicians and specialists seeing different things. She says, I had a recent radiologist who measured previous CT scans and then measured the tumors in the new CT scan. And they came out with different measurements than the radiologist who originally looked at them. How is that possible that they come to different conclusions? And the old CT scan had tumors that were larger than the new measurements. Now, I do know this patient had some chemotherapy in between, so perhaps that's impacting things. But yeah, so, and one specialist said they preferred their measurements over the other one. So maybe talk a bit about that too.
Right, we always like our own radiologists, right? Yeah, so, you know, it's a common frustration, and yeah, there could be lots of reasons why that could happen. You know, one, it could be maybe one radiologist just doesn't see a lot of patients with appendix cancer or with peritoneal metastases. And, you know, there's certain, just like, you know, there's surgical oncologists, but not all surgical oncologists do HIPEC. And so, you know, if you don't do this a lot, you tend to miss things. And that's true for radiologists. They may find areas, they may see things they don't see. So that's one explanation. The other one is, you know, sometimes there is some subjectivity to this. I know, you know, we like everything to be black and white, perfectly objective, but let's say, I don't know the situation here, but, you know, sometimes people have lots of different tumors. You know, there's actually multiple tumors throughout the abdomen. It kind of does depend a little bit which one are the radiologists referring to when they give a measurement, and exactly which slice do they give that measurement. So most good radiologists, when they give a measurement, they'll give the actual, each of those slices has a number, and they'll actually say, oh, you know, series 3, slice 48, we see a 2.5, you know, millimeter lesion, blah, blah, blah. And that's really helpful for any subsequent radiologist, and they can say, oh, I see where they're measuring this. Because sometimes if you go up or down a slice, it might be slightly different. And so, you know, so that's where the variability can come in, and especially if there's multiple tumors and multiple things that are being measured, it's easy to kind of get confused and you know, slightly measure them slightly differently. The tumor hasn't changed probably, and it's not that one radiologist was wrong or right. It's just exactly what point of the tumor they measured it, and you know, once again, that's where if it's a subtle difference, that may not be so important. You know, but if we're trying to measure response to chemotherapy or follow, is it growing, then that does matter. And, you know, it can be tricky sometimes.
That's great. That's great. Thank you. Now, so Dan asks about an appendix cancer that's gone to the small bowel and is not detected by the CT because it's not large enough. Is there a technology to measure its size and growth other than surgery? I imagine laparotomy plays a role here, but what are your thoughts?
Yeah, I mean, yeah, so, you know, MRI can be helpful for the small bowel, so it might be worth considering that. But sometimes still, it's unremarkable on MRI. Yeah, and then, you know, I think the thing about you know, I talked about the sensitivity and how disease is missed, but most of the disease that's missed is very small. Even tumors on the small intestine, I mean, eventually they're going to be visible. Now, you know, if we miss an opportunity to intervene because we had to wait until it was visible, that can be a problem. But sometimes that doesn't matter. Sometimes if we know there's disease there and we're treating someone or watching, it may not make a big difference that we can't measure it accurately from scan to scan, but then eventually it's going to get large enough that it's going to be visible. You know, I think I saw a question in here saying how it was very obvious to the person how, you know, what we were looking at are these, you know, extensive cases or low. Yeah, most of the cases I showed are pretty clear, right? I don't want to, you know, for a reason, it's very obvious, but you're right. There are much more subtle situations where it's hard to, is that fluid? Is it, you know, and there's times where the radiologist finds something and I don't see, or vice versa. And then I might ask them and say, hey, is this real? And they say, oh yeah, maybe it is, you know? And so I obviously showed kind of the clear-cut examples, but it's not always so clear-cut.
Yep. And then, so laparotomy, right, you said that it's there's nothing better than being able to get inside and take a look, but I imagine also it can be tough to see everything that you want to see with a laparotomy.
Right, so that's why, you know, we prefer laparoscopy with just the camera and the look. You know, a laparotomy, you know, usually means like a full open surgery, which we do, but, you know, most of the time, we rarely will just do a full open surgery just to look and see. Usually it's a situation where we suspect there's disease recurrence and we're ready to deal with it at that time. And so we'll say, okay, we'll explore someone and look in them. And if we see disease, we'll actively address it. Obviously it's good news not to find disease, but then the bad news is you had an operation to figure that out and have to recover from it. So I think that's kind of a last resort. Certainly an open surgery is a last resort, but if someone's not had prior extensive surgery, a laparoscopy is a great way to look inside with just, it's an outpatient surgery, small little incisions. It definitely requires anesthesia, has risks, but it gives us a lot more information.
Got it. Good. So Kelly asks, if you have recurrence after cytoreductive surgery in HIPEC, where the omentum was removed and peritoneum stripped, what does the new tumor growth attach to? So organs and abdominal muscles, or do tumors float around the abdominal cavity?
Yeah, probably all the above. So some of the peritoneum does grow back. If it has an opportunity to grow back, it actually will. When we reoperate on patients, sometimes the peritoneum has regrown, and so the tumors can grow on that new peritoneum. But yeah, they can grow directly on whatever's underneath the peritoneum. They can grow there on the muscle and sometimes on the organs themselves. That's one reason why whenever we go back a second time and have to do another surgery, it's always more challenging because the tumors are in different locations. What I always say is, well, we removed all of the disease before, so it's only going to come back in difficult locations because that's just where it was left, and so that's always a challenge. Yeah.
Good. Thank you for that answer. And then Charles asks, what's the reasonable resolution? What do you anticipate finding? Like what centimeter size do you expect to see for tumors?
Yeah, I think unfortunately for most of the peritoneum, it's probably 1 centimeter. So 10 millimeters is really the lower limit of detection. I mean, you can see smaller lesions, but it's only if you get lucky. And what I mean is, if you think about it, we're looking, like, let's say we're looking at the edge of the small intestine, it's round. I don't think you can see my fingers. It's round, but, it has natural irregularities on its surface that might be even up to 1 centimeter in size. And so you see a little bump on the surface of the small intestine. You can zoom in on a CAT scan, but even if you zoom in, you still see this little bump. Is that a normal bump on the bowel surface, or is that actually a tumor? And, that's where it gets really tricky to sort out. And so that's why that detection limit is probably about 1 centimeter. When we talk about liver or lung lesions, we can pick up lesions that are probably 1 millimeter or 2 in size because we're inside this structure that's pretty much all one density. And then you see a little tiny 1 millimeter lesion. It's actually pretty easy to pick out. But when you talk about the peritoneal surface, it's difficult to do. Yeah, so probably 1 centimeter.
That's terrific. Well, with that, Dr. Baumgartner, we're going to first say thank you for your time. We really appreciate you taking your Saturday morning and being here with us. And I just want people to understand that the UCSD Moores Cancer Center here in San Diego is one of our best institutions. And so not only do they have great surgical oncologists, they have terrific medical oncologists and research happening there too. Melinda wants to remind us that she's there for a clinical trial with Dr. Patel today. You can send an email to info@pmppals.net. We'll be happy to let you know about the clinical trials we're aware of and help you access them if you're interested in doing that. But definitely want to give a shout out. I'm privileged to live close, 10 minutes away from UCSD and call Dr. Baumgartner a neighbor. And I just want to say for everyone here how much we appreciate all that you do for us as patients, and please send the team and Dr. Lowy and Dr. Virapong, Kelly also our compliments and thanks, and we hope you have a great holiday season. Thanks for being here, everyone. And we will be here next week at the same time, 8 a.m. Pacific, 11 a.m. Eastern.
Chris, one quick update on somebody else, a regular participant. So Kath from New Zealand has her surgery this coming week. So Kath, we're wishing you the best. I
saw Kath earlier, so glad to see you, Kath. And then if you have further questions, you can send them to us. We can connect them with Dr. Baumgartner and make sure that those get answered. And if you're interested with a consult, we'd be happy to make that connection too. So again, thank you to everyone for being here for the highlight of our week. And remember, PMP Pals has hope for you, and we hope to see you next week. Thanks, everyone.
Thanks.
Bye-bye.
Bye.